used.
Okay.
So we will just try to start. Is this Dr. Nasrullah, Dr. Sheikh? Is it you, Dr. Nasrullah?
Yes, Dr. Zishan. Assalamu alaikum.
Walaikum assalam. How are you, sir? Sir, welcome
Fine, alhamdulillah.
welcome everyone on board. So today we will be discussing about anaphylaxis. Okay. And the first question from where we started, as Zunaira asked. So Dr. Nasrullah, if you can just explain what is difference between anaphylactic reaction and anaphylactoid reaction.
Thank you very much, Dr. Zishan. Anaphylaxis and anaphylactoid. Anaphylaxis reaction is immune mediated reaction. We can define it. It is a severe, potentially life threatening hypersensitivity systemic response. So this is immune mediated, like IE, immunoglobulin E mediated. While anaphylactoid reaction is similar, like life-threatening reaction, but that is not immunoglobulin mediated.
Yes, IgE. It's not IgE mediated. Okay.
Yes, exactly.
So anaphylactic is IgE mediated, and anaphylactoid is non immune mediated, and there is something which is acting as an allergen or as a cause of this reaction directly. Okay.
Yes, exactly. Directly, like some drugs or some toxins or any chemical, they directly hit on the mast cells. Then the mast cells got degradation, and they release these inflammatory soups outside, like histamine, prostaglandins, prostacyclins, cytokines. All these are released by direct hit of this drug molecule.
So next question is that and the reactions related to anesthesia usually are anaphylactic or anaphylactoid?
Usually anaphylactoid reactions.
Yes, these reactions which occur in anesthesia usually are anaphylactoid reaction. Okay. So we will just go in a little more detail. Nasrullah bhai. So if I ask, because it is sometimes it's easier to have a concept and then it will be. So now the first thing that I want to discuss, that during anesthesia, okay, if you want to know that it's undergoing GA or, for example, regional. Okay, so under anesthesia, what will be the signs? And for example, in regional anesthesia, what will be the symptoms of anaphylaxis? What can be the probable symptoms? If you highlight first for GA.
Yeah, we can start. It can be divided in the grades: grade 1, grade 2, grade 3, and grade 4.
Okay.
So if it is mild reaction, it is a mucocutaneous response. It's a grade 1 reaction. So only erythema, angioedema, some skin manifestation will occur grade 1 under general anesthesia. Like we have given some medications initially after IV induction, we saw some erythema on the skins around the IV cannula. So this is a type, we can say this is a mild reaction, grade 1 reaction. And grade 2 reaction, in grade 2 reaction, there are cutaneous manifestation, including, but there is also bronchospasm, some systemic involvement like bronchospasm, and there might be some hypotension. So it will be grade 2. And grade 3, this is a bit more serious. There, including all these skin manifestation, hypotension, and bronchospasm, there may be arrhythmias and cardiovascular collapse. So this is grade 3. So it can happen during under general anesthesia. And grade 4, that is completely cardiopulmonary collapse, means cardiac arrest.
Yes. Yes. So this is what you were telling. Okay. If it is possible to memorize this thing, it may be asked, or they can ask in as a concept. But I will just add to what Dr. Nasrullah said, that usually under anesthesia, if for example, if it is occurring, there will be two scenarios. If it is occurring at the time of induction or when you started a medication, okay, any medication intraoperatively, okay, so there will be one sort of manifestation which can occur, okay, because the surgery has not started and you can visualize the patient is not covered and everything. So you can identify whatever grades are the initial phases, you can identify. But if it is in under anesthesia, unfortunately, maybe hypertension, hypotension, okay, and tachycardia may be blunted by the anesthesia drugs. So you cannot maybe pick. So first sign under anesthesia, which may be evident to you, is increased peak inspiratory pressures. Okay. So that's why this is of utmost importance. Though this is the message in which the thing which you told. Okay.
Yeah, exactly. You are right.
So just pardon me for a second. Okay, please. So this is one message. I hope you understand. Otherwise, the signs are the same, because what is happening that, as Dr. Nusla told, there are release of, because of any reason, there is a release of inflammatory mediators, histamine and leukotrienes, and they are causing hypotension, and they are causing increased airway they are causing bronchospasm. So if you can highlight a little bit of about angioedema, because angioedema is a very serious complication.
Basic, yes, yes, Dr. Dishan. Regarding this angioedema, what happens usually when there is hypersensitivity, when this hypersensitivity reaction occurs, what happens? The histamine release, and that histamine causes there are the endothelial cells in the capillary inside the linings. These endothelial cells get contracted, and the gap between the cells, endothelial cells, increase. Therefore, the blood come out from the intravascular compartment to the blood, from the blood vessels to the outside the blood vessels or capillaries. So these causes angioedema, rashes, and some red skin. This is because of this histamine contraction and increased gap in the endothelial cells, and blood comes out. This is the phenomena.
Yes, like there is increased vascular permeability. Okay, so
Yeah,
if you want to have a detail, and for us, most dangerous places if it is near airway. Okay, it may be in the neck, it may be in the airway, like presented as upper airway obstruction. It can be like that. So that is the
exactly.
most serious presentation or serious thing which can cause sudden problems. Okay. So rest of the management will be the same. Whatever the factor is, we will just try to have a look at what is the drill. But if you just want to have a look at the concept of angioedema, this is what you told. Okay. So
exactly.
Just a second. So now, for example, for any good reason, for any good reason, if anaphylaxis occurs, so there is a drill. There may be different colleges and different have made it. So if it happens, what will you do? Like intraoperatively, you picked it that you had started some culprit medication. For example, you had started blood. There may be hypersensitivity reaction. You may have started any antibiotic. Okay, you gave some muscle relaxant. So whatever happened, whatever the cause is, what will you do?
The first of all, stop the triggering agent.
So
number two, ABC, airway, breathing, circulation, and number three, call for the help, and immediately secure the airway. If the patient is already intubated, no problem, thanks God, and giving 100% oxygen, and epinephrine if it is sure, we
you are
understand this.
just you are just missing one part, which may be of there may be that you have to stop the surgeon. This is
Yeah,
you can
exactly.
add it in stop the surgeon, call for help, and then
Yeah.
maintain airway breathing circulation. Okay.
Yes.
And epinephrine.
1 second, Dr. Zishan, I have a call. I will
Okay.
join you. 1 second.
Okay. Okay. So in this time we will
You can
just try.
continue, please. You can continue.
Yes. So actually in this time I will just tell you that now what will be the treatment modalities, because what you have to do, you have to first of all you have to stop the whatever the triggering agent. Then of course all the havoc which is being done by it. So mainly it will be in the form of airway problems, or it will be circulation problem. Okay. So you have to maintain the airway. You are giving 100% oxygen if the patient is not intubated. So you, and then you are giving circulatory support. So what support will be that you are, because there is sudden vasodilatation. So you are giving epinephrine. Okay. So there is a lot of debate about whether it should be given IV or intramuscular. Okay. Or subcutaneous. And this is first thing. And how much should be the dose?
Okay.
Yeah, you are free now?
Yeah, I am free.
Okay, so that's what we just, so there is a lot of debate about, there are a lot of confusing questions about it in MCQs. Okay.
Okay.
So practically, if you ask me, I don't think so you will agree to it. Practically, if something like this happen, we never give intramuscular.
Never, never,
we
ever.
never give intramuscular, but unfortunately, if you read the guidelines, which I understood that it is because anaphylaxis can occur in front of an anesthetist and anaphylaxis can occur in front of any person. So I think for non-trained people who don't have the experience of using epinephrine, I suppose that this may be the reason that they have put it intramuscular in some of the guidelines. So this is what I understand. Okay, because maybe even in the MCQ you will find the option of intramuscular. Okay.
Also, maybe if there is no IV cannulation in case.
This may be also a reason. Okay, this may be also a reason. Okay, so
yes, sir. Yes, I just want to add, it's dependent upon the situation. If patient, like as Dr. Nasrullah told, he's right, absolutely. If depends upon the MCQs, most of the time the MCQs give the scenario that patient is OPD or outdoor patient or patient somewhere not intraoperatively. Then we give intramuscular because there is no time to maintain IV line and you have no equipment. That time preferably you have to give intramuscular. One patient is there is scenarios intramuscular, then 1 mics or 100 150 mics IV preferably.
No, how much intramuscular dose will be?
10
intramuscular
microgram per
0.5
kg.
milligram intramuscular 0.5 or 500 mics.
500 mics.
Or and intravenous 1 mics per kg in pediatric and adult also around about 100 150 mics.
Yes. Okay. So that is the basic this basic message. And
Dr. Jamil, shall I add here one thing? It is now recommended 10 microgram per kg body weight adrenaline dose. 10 microgram per kg body weight IV.
Okay.
Yeah, no, sir. If intramuscular, then for adult is 10.
Yeah.
For adult is 0.5 and for pediatric is 10 mics per kg intramuscular.
Okay.
Because IV, I think it is like that. Okay.
Yes, sir,
IV 1
he's
mics
right.
per kg.
The IM
1
is
mics per
500
kg.
mics.
Just let her speak. Yes. What are you saying, Zinera?
Sir, he is right. The IM is 500 mics.
500 mics. Okay. So that is so in addition to just improving, this is something we actually practically we do a lot. That if the patient is standing, maybe patient fall down, or if patient is lying flat, you can raise the leg. Okay. Because it will be also a big help to
Exactly. You are right.
increase the venous return, and they have even put it in this safety drill. They have put it. Okay. So this is a very effective way to do it. Okay, so now what else problems will be there will be related to histamine. Okay, so and there is inflammatory response. So what medication would you like to add in addition to, of course, this epinephrine and giving fluid?
In case if the blood pressure is not responding to the epinephrines, we have also the vasopressin, noradrenaline, and if the patient is already on the beta blockers, we can give glucagon.
Okay, these are associated thing. Yeah, like you will be following the protocol, but usually the other medication which you are giving are one of them is antihistamine. Okay.
Yeah, that is yeah, later on. Yeah, later on, there is no any immediate role of the antihistamine and corticosteroid. There's no any immediate role. So later on, we can give this antihistamine and the steroids.
Okay,
But
so in between,
in emergency, there is no any role of antihistamine and corticosteroids.
okay, so there is one more thing which we have to do at that time is that we have to try to find out the culprit. This is one thing. And we have to, just to confirm the diagnosis, we have to send the tryptase level. Okay.
Exactly.
So whenever we will not delay the resuscitation, so stop, we have to send the sample for tryptase, no, but you are in side by side, if you can just take a sample and send tryptase level, and then we will be repeating serial levels, okay, to get a proper diagnosis. Okay, so
yeah,
and later on these patients will be referred for a proper diagnosis, and they will have the bands. Okay, so
yeah, immune and allergy clinics. Yes, you are right.
Yes. So we will be giving some antihistamine later on, steroids, and if it is not responding to a bolus, you will be giving the infusion. Okay, and then there is, because bronchospasm, so you are giving some bronchodilators. Okay.
Yeah.
So that will be doing some word. What is this tryptase? What is this tryptase enzyme?
It's a protease enzyme.
Okay, it is there in the mast cells. So whenever there is mast cell degranulation, this will come up, and this will be telling you an indirectly way. It will be released both in anaphylactic and anaphylactoid reactions. Okay. So it is the diagnosis of it. The only this is that anaphylactic reaction usually occurs in a predisposed patient. Okay. And anaphylactoid reaction can occur even in the first time. Okay. So they have written few words about tryptase, so you can just have a look on it. Okay, and in MCQs they can even ask these things. Okay, they can ask about the levels, they can ask about the baseline levels. Okay, so and then extra, this is something extra. Urinary methylhistamine is the principal metabolite of histamine, but it's difficult to interpret outside the normal range, although it will be detectable for longer than plasma tryptase. Okay, and then if they ask you further management, what you will do, you will report it, you will document, and if you are appearing in some international exam, you have to document, tell about that, you will refer the patient to the primary GP as well. Okay, so you will be adding these few things when you are doing it. Okay, and later on you will refer the patient for this skin prick test as well. Okay, so this is a clinical anesthesia viva book. This is a wonderful book for review. Okay, and I will advise all of you to have a look at it. Okay, so one thing just related to this is
sorry, if you allow me, I just tell 2 words about the tryptase. You already told tryptase also is sometimes in MCQs they give the question that there is some different enzymes that is already pre-synthesized, or they are in the vesicles, including histamine, tryptase, and 2 other enzymes. This neutrophils attracting. Okay, I'm not sure, but the tryptase pre-synthesized, and you already told that. Sorry.
The other is TNF, tissue necrosis factor.
Tissue necrosis factor, yes, and it releases in both anaphylactic and anaphylactoid reactions. Anaphylactic, as you already told, there is involvement of immunoglobulin E, and in anaphylactoid, there is no involvement of immunoglobulin E. It's directly any chemical mediator can release these mediators from mast cells. and we take it the 0 times, just for the baseline, and its maximum excreted in 4 to 12 hours, and it comes to the baseline after 24 hours. It's used in diagnostic measures. And also, when we take the sample, we have to send the sample in low temperature. When we take the serum or we take in the test tube, we have to send in ice box or in some specific special container where the temperature is low, because it's rapidly, in the other, decreases, or in other samples, now it's consumed. That's why, we take a baseline at 4 hour and at 12 hour and 24 hours tryptase, just to take the diagnostic measure, and also is tell us about the amendment. These are the 2-3 words about the tryptase.
Okay. So, Zunaira, if you want to just discuss about latex allergy.
Yes.
So, what is latex?
Dr. Zishan, sorry, Dr. Zishan, can I interrupt to finish this tryptase at here, because all the colleagues are here. There are also MCQs of which tryptase is more specific. There is beta tryptase also.
Alpha.
So
Alpha, I think alpha tryptase is more specific.
So which is
Yes.
the more, not alpha, beta tryptase is the more specific, because
Beta. Okay, yeah. There is alpha and beta.
Yeah, alpha tryptase is also increased in trauma, myocardial infarction, and amniotic fluid embolism.
Yes, in pregnancy also. Yes, in placenta also.
Alpha in, just repeat please, alpha in amniotic fluid embolism. What else?
Alpha tryptase in trauma, severe trauma, myocardial infarction, and as well as this amniotic fluid embolism.
Okay, so this is about tryptase.
This is tryptase. So beta tryptase is specific from the mast cells, which is from the immunoglobulin E mediated. 99% of the total body tryptase is in the beta in the mast cells.
Very good.
So this was a point here to be noted, and especially comes in the MCQs. Okay.
This is something new for me as well. I have never.
And the peak level of tryptase after the reactions comes within 20 minutes. After 20 minutes of the reaction, the tryptase levels falls down, and therefore we took second sample, the final sample at 24 hours. Then we compare from the first sample immediately after the reaction, then second sample at 60 minutes, and third sample at 24 hours. So we will compare all the samples. When it is our third sample is came down to normal level, or compared to the first level, first sample is very high. So means now this is sure 100%. This was anaphylactic reaction, anaphylaxis. It was anaphylactic reaction.
Okay.
So compared to all three these samples.
Okay. So before we go to latex allergy, I will just tell you that there are different, because this is important with regard to latex allergy, that what are different types of hypersensitivity reactions. Actually, there are 4 types of hypersensitivity reaction. One about which we were discussing. This is IgE mediated. Okay. So rest of Shamail, Zunaira, did you read about it?
Yes, sir.
I'm sorry. Yes, please unmute.
Yes.
I'm sorry. I'm just
It's okay now.
Yes.
It's okay now. Yes. So it's basically because of the water soluble proteins in the latex, or it can be the powder, or it can be because of the other materials that we use in the theater, like the equipment made of latex. And it's a hypersensitivity reaction. It's more common in the.
Actually, I will just interrupt you. Actually, that's what I was telling you about hypersensitivity reaction, that latex allergy may be in the form of type 1 hypersensitivity reaction. Okay. Or it may be type 4. Okay. delayed hypersensitivity reaction, which occur in a granulomatous lesions. Even tuberculosis is also type of this one type 4 hypersensitivity reaction. Okay, so one type we have discussed. So one type is one IgE mediated, as it's shown in this text which I am showing to you. Okay, so type 1 is IgE mediated. Okay, and all the thing which we were discussing was about the same as we discussed. This was type 1. There are two other types. We will just skip for a while and then we come to delayed hypersensitivity reaction, which is cell mediated without complement activation and without the formation of antibodies. Okay, the reaction results from combination of antigen with T killer cells, lymphocytes, and macrophage attacking the foreign material. So this mechanism, and this is the development of contact dermatitis, and that what is the relation here is that this latex allergy may be either in the form of type 1 or in the form of type 4. Okay, so this is the relevant concept about latex allergy. We can just have a look here at the rest of these two types as well. One is cytotoxic, which is mediated by IgE and IgM antibodies, which react in the presence of complement to mediate reactions which cause cell lysis. Okay, so hemolysis following this this hit is an example of this thing. Antibiotics, some of the antibiotics, they are causing this cytotoxic reaction. Okay, so this will be more hemolysis will be, I think, if I'm not wrong, just correct me, that it will be more in the susceptible RBCs as occur in G6PD deficiency. Okay, so this will also be causing the hemolysis. Okay, so third one is this immune complex mediated, the reaction of antigen antibody, and they are forming immune complex which we call precipitin, and they deposit in small vessels in the form of so they are causing this inflammatory reaction which occurs in rheumatoid arthritis or SLE. Okay, so they can ask you an MCQ about these type 4 different types of hypersensitivity reaction. Mainly an anesthesia which is worrisome for us, usually it is type 1. And rest of the things are usually in chronic conditions usually. So now so what will be the triggering, as you told that there are some patient who will become susceptible. Okay, so there will be previous history or there will be repeated
في جروب اسمه بص
yes
بتاع واحد باكستاني اسمه سيد ما اعرفش ايه كده اللي هو اسمه انس.
Okay, so there will be repeated this urinary catheterization or healthcare workers. There is a relation with spina bifida and some history of atopy to certain fruits. Okay, so now that another question will be Zunera, that you can, that what anesthesia equipment or in OR what things will be latex?
First of all, the gloves, the equipment used for the airway management, it might be, and
like LMA, maybe
LMA.
this breathing
I'm
circuit.
not. Yes, and what else? What I read is like it may also be possible because of the powder present, because of the latex. So the all OR environment should be made powder free. Like the patient should be put in the list in the first, in the morning.
Okay.
And the urinary catheters, yes, and the other catheters. I actually am not sure about what is seriously, like what is literally made out of latex.
Okay, so
in
you
the
see
theaters.
these are the this one the contents which can have latex. Okay, so all
If
these
you saw interrupt, mostly there is Foley's catheter. The old mask, black color, are old breathing circuits. They were also made of from latex. Gloves, mostly, this from the rubber plant. They also made up of latex. There is powder or sometimes the material. some laparoscopic instruments, before it was with the rubber and the latex, and now they are changed with the plastic, PVCs. And also catheter, nowadays there is silicone based catheter, which also they replace. But even this, the cheaper one, yellow one, the skin color Foley's catheter is made of latex. And most of the time there's surgical instruments that they have some component like a screwdriver or some, in spine surgery or another surgical instruments, there is some part of that silicone, not silicone, sorry, the latex or rubber portion that causes mostly to the latex allergy. And the medical staff, I mean the nurses or the doctors, they are more prone for the latex allergy. I just want to.
Yes, you just told. So that's what actually, which group of patients will be at risk of latex allergy? Okay, occupational exposure, as I told you, healthcare workers doing procedures, and then multiple operations, especially laparotomies, repeated bladder catheterization, okay, atopy or allergy, as was written in the book, okay, history of anaphylaxis with no identified provoking agent, okay. So unknown, if you can label it, you can consider it to be having some problem related to latex, okay. And women are at higher risk than men, okay. So these are at risk, and then the things which you have to take care are, they have just made a chart about it. And like it can be with anything, you see, syringes, cannulas, CVP lines, spinal needles, epidural catheters, nerve block needles, anything. So you should be, if you are dealing a patient with the this one, patient with the suspected latex allergy, you have to take care of these things, okay.
Dr. Zishan, just regarding the powder with latex, just to clarify here, the powder is being added just for helping in the donning and doffing for the gloves. Just powder was being added just for removing easily and putting inside the wearing the gloves. The powders are therefore the powder causing the problems later on. Post-operatively, powder was creating the granulomas, and adhesions of the gloves. So therefore, the powder has been removed from the gloves nowadays.
Yes, yes. And some people are sensitive, even myself. I cannot wear gloves a lot. It becomes a lot of problems. So a number of people, even with wearing the gloves, that sort of, you can say, you can label it as type 4 reaction. This contact dermatitis sort of picture, which can occur. Okay.
Okay.
So that is what we will be doing. The basic principle of, if it is occurring, the anaphylaxis will be the same. Okay, they are asking you as an latex, so it can occur slightly after some time. Okay, and it is actually difficult to identify. So intraoperatively, maybe it is Jamil, can you just tell that, is there any something specific for latex, or there will be similar like any anaphylactoid reaction, am I right?
The only, sir, the duration, most of the times they ask about the duration. It started after 30 minutes of the procedures, even if it's in type 1, not like other IV drugs. This is the thing so special. Or the other thing I already told that most of the patients have some food history, like from kiwi, banana, avocado, and these the things, specific for latex.
Okay. Okay, so these are words about this latex. You can have, these review books I have just opened, and I will ask you, I will highly recommend you that you should read these books. These books are much better than any so-called textbook. Okay, you see, these all the things which you, Dr. Nasrullah was telling, it's all written here. Okay, so
Dr. Zishan, shall I add here regarding the latex, how to diagnose the latex allergy? They have told that you can, if you have blood investigations, so you will have an immunoglobulin E. If it is a latex allergy, and are there any skin redness is there from the gloves. So how to do these tests? They're called the provocation test. Provocation test means the little piece of the the latex gloves
itself can cause.
Yeah, it applied on the skin of the patient for 15 minutes, then there will be a redness. If there is no redness, then you can put all the latex gloves weight, totally weight with the water, and put on the hand and watch for some time exactly, I don't know. Then if it is still not there, no reaction, no skin manifestation, then rub the gloves with the patient's skins. Then you can find if there is any redness, then it means the patient has this test, this positive, this latex positive.
Yes, actually, all these tests are always being done in a controlled environment where
Controlled environment.
Resuscitation
facilities available there.
Yes. Okay.
Yeah.
So actually, this is one thing more thing I wanted to show you is actually this NAP6. NAP6 was done national audit project, and they do studies, and then they find some culprit. They find some key finding. So they find among the all the causative factors, what is the number one cause now? It is
chlorhexidine. Chlorhexidine.
No, it's antibiotics, no?
Antibiotics.
Antibiotics. Okay.
Okay, antibiotics, and among neuromuscular blockers, rocuronium.
Succinylcholine and rocuronium, both.
Both, but among, if you compare between rocuronium and suxamethonium, it is more with rocuronium.
Okay.
Okay. So you don't, if you want to have a look, it is there also in this one. Of course, it is related to chlorhexidine as well, and you will find a number of things, but you don't need to cram each and everything. Okay, you just have to look at the key finding, because whatever MCQs they will be, especially for you, Dr. Nasrullah, for in Irish exam or any international exam, if they are asking, they will be asking according to some guideline. Okay, like similar example is about maternal mortality. If they are asking you, they want to what is the finding in the latest CMAC, confidential inquiry into maternal and child health, CMAC. So similarly, if they are asking you something about on which they have some guideline on, or some study, or this sort of like a very big meta-analysis of this like the national audit project, they are expecting you to tell, or their MCQ key will be according to these recommendations. Okay.
Okay.
So for that, you need to have a look on these recommendations whenever you are appearing in our in British exams or any international exam. Okay. So it is there. You don't need to read each and every line about it, but I think it is, if you just read these key findings and recommendation, you will find a lot of knowledge. Okay. These are too much details. They are just telling you, because usually any drug can cause it, any factor, antibiotic. Remember the message is antibiotic and this one muscle relaxant. Okay.
Yeah, exactly.
Sorry.
You are right.
Okay. So just few things. If we have almost covered all the questions, what are different timing histamine releasing drugs used? Okay, what are different? Yes, another question in related to it. What are common and histamine releasing drugs?
Morphine.
Very good. What else?
ACE, no, it's a liquid. Yeah, ACE inhibitors.
Hypentol.
It's NSAIDs.
Okay. Like, if you want to be specific, try to start from the groups. So if you will, you are targeting each group, you will find some medications which are related to histamine release, and some medications you will be less. Okay. Like among the muscle relaxants, the most is with tubocurare.
Atracurium.
Yeah. Cis and atracurium.
I'm sorry.
Yeah.
Mivacurium.
Mevacurium. Yes, Mevacurium, I think it's not being, I'm not sure. Mevacurium, I think yes.
Yes, it is meva and atracurium. Yes.
Yes, and the more,
Cis-atracurium now.
and which will be the least or not, which does not release is cis-atracurium. Okay.
Yes, you are
Yes,
right.
because
Dr.
of the
Nisha.
structure. The structure is different for cis-atracurium.
Yes, so we covered some about words about latex allergy. They can ask you about types, mechanism, how it occurs, presentation, signs, symptoms, predisposing factors, management, and what to avoid. This is the questions. If you prepare it, any MCQ will be covering from ease of the thing. Yeah, hypersensitivity reactions we discussed, type 1, type 2. Actually, for us, it is most common is or most concerned is type 1. But of course, it can occur. The other ones also can happen. Okay. And then whenever they are using these things, you should be knowing histamine releasing drugs. You can find out and make a list, and similar list you can make for QT interval prolonging drugs, enzyme inducers, enzyme inhibitors, and things like that. Okay, so it will become easier for you to at the same time you will be doing a like you are making your notes in that way. Okay. So just a second. We are just FRCA mind maps. Actually, everywhere same things is written. Okay, you just it's up to you to use the source. You will find everything written in the same way. So you cannot say that it is coming from that book or it is coming from that book. It is up to you. But I will suggest you that if you can print FRCA mind maps and add on things on it, it will be a very good. A good way. Okay, this is all about anaphylaxis. Any comments, any thing you want to add, anyone wants to add something? You know,
Dr. Zishan, I would like to address here regarding the recent, you sent me the recent article. It was first time I also noticed, before I never know, the DRESS, DRESS.
okay.
This is DRESS. This indicates D for drug, R for reaction, with E for eosinophil. Drug reaction with eosinophil and systemic symptoms. This
Drug
is called DRESS. Yeah,
reaction.
drug reaction with eosinophilia and systemic symptoms.
Yes, you know.
First time in my life I understand what is this DRESS. Today you sent me these. Today you sent in the group these articles. So this says that most frequently with aromatic anticonvulsant drugs like phenytoin, carbamazepines, and phenobarbitons. These all drugs can cause this DRESS reaction. This DRESS reaction is when I looked in the Google, I found it's very dangerous. The DRESS reaction, it creates some skin manifestations like measles-like reactions, papillary reactions. It involves every system of the body. And this is from the drugs. There are many drugs listed in this article. Even the vancomycin, which we are using antibiotic, many antibiotics I found there. All these medications causes this DRESS reaction.
You know what is the syndrome related to vancomycin?
Redman syndrome.
Redman syndrome.
Redman syndrome. Okay, this is also a question which they can ask you. Okay, so you know this is another source. You can have you see anaphylactic shock, how it happens. There is vasodilatation, increase vascular capacitance, reduce ventricular filling. Okay, and there is at least capillary permeability, angioedema, which is reducing ventricular filling, like preload is decreased. Okay. And then there is airway of compromise, bronchospasm leading to hypoxemia, reduce pulmonary blood flow, reduce cardiac output. It will, so there will be less blood flow to the lungs, and contractility will be decreased. Blood pressure will be, so like whole of the picture. That one thing is adding to it. Okay, and as they have written is based on NAP6. Yes, Dr. Sadia.
Sir, these colloids can also cause this anaphylaxis
Of course,
and other benzodiazepines. Diazepines can also cause this anaphylactic reactions.
Actually, practically any medication can. Colloids are more. Benzodiazepine, I'm not sure about it. Thiopentone can cause propofol, anaphylactic.
Yes, these induction agents like thiopental, propofol, etomidate.
Yes. Okay. So some few pearls. You know, this source is also very good, and this is anesthesia and intensive care medication medicine. It is all the to date articles are there in the link. Okay, so I am unable to put this source, this anesthesia and intensive care medicine, in topic wise folder. So if you want to search them, it is better for you to have a look on the year wise folder. Okay, so you will find this is very academic and very easy and actually very methodical. Okay, so this is when anaphylaxis should be considered: unexplained hypotension, unexplained bronchospasm, unexplained tachycardia, angioedema, unexpected cardiac arrest, cutaneous flushing. Okay, so these are very good charts. And you know, the people who open the book and then become worried, sir, from where we have to study, just try to sniff. You just have to do, you know, only I think this academic flirting is halal. Okay, if you want to do this flirting, this will help you a lot, because you will never find these things written in one book, in one place. If you just try to find out the answer, you will find your life totally different. Okay, so all these articles are there in the link, and I think we have covered this topic in a nice way. So tomorrow we will be coming with the next topic. Okay, so maybe inshallah I will update you what topic will be. Any question before we finish?
No, thank you very much, Dr. Zishan.
And thanks to everyone, all of you. Okay, a special thanks to Dr. Nasrullah. This was your first interaction with us. Okay, so
Yeah.
inshallah.
Inshallah, we'll continue.
Okay, dear everyone. Bye bye.
Thank you so much. Thank you, everyone. Thank you, Dr. Jamil.